with my colleague Reka, who's sitting right next to me. We were in the Access group and talking about the role of mobile health and nutrition teams. And would you like me to share this slide, or do you want to just talk? Sure. Yeah, okay. I think I should be able to share my screen.
Okay, can everyone hear me?
We can hear you, Reka.
Great. So in our group, we were looking at the mobile health services. So one of our recommendations was that mobile health services in contexts where displacement is likely or static facilities may be damaged or inaccessible due to conflict. So we do recommend them, but that we need to have some clear strategies on when and where they should be activated, particularly how they should be scaled down, and then about the service and staffing and the budget required. So some of our key considerations were the fact that, first of all, this should be for exceptional circumstances, that this is not the same as your regular outreach or extension services, which are happening to the health zone from a health facility on a weekly or monthly basis. This is really an approach to move along to areas of high caseload or areas where the health facility is either inaccessible for whatever reason or damaged beyond repair. There was a lot of discussion about how to run these mobile services without drawing on and damaging the existing health system, and how to have a health system strengthening approach. So very important, first of all, to not be pulling key staff from functioning health facilities, but there was a great idea in the group about using the staff from the facilities that are inaccessible or destroyed, using them for the mobile team, and then transitioning them back when those health facilities are up and running. There was also some discussion about a transition period for scaling down, and where, how to hand back to the health facilities, and the importance of having the health facilities strengthened and built in parallel. So instead of just putting all our attention into the mobile services, how do we in the background start to help those health facilities reestablish, get the basic services back up and running so we can transition? There was also a great idea in the group about linking to the community and about ICCM and ICCM Plus, and where is the role of community, so ICCM, integrated community case management. Where does the role of integrated community case management come in? And if you can kind of link those different ideas, you would be able to have the community treat some of the more basic illnesses, and then the mobile health teams treating the ones that the community can't handle. There was quite a bit of discussion in different contexts. I suppose it's either, in the context of Ethiopia, it was raised the Ministry of Health is using this approach, but that in many contexts, it's mostly donors that are funding the mobile services, while the Ministry of Health is funding the static health services, and maybe an advocacy point for government to consider investing in mobile health services as important. We had then a point on preparedness, the importance of being prepared to use mobile health services, looking at the seasonal calendars, very much integrating this into the CMAM surge approach about how we scale up and how we scale down, and in moments of peak crisis with peak caseloads in certain locations, a mobile service may be the appropriate answer. And then we also talked about just some questions and thoughts about how do you meet the wash needs, the water needs, particularly for mobile health services, and some ideas around pre-positioning water, ensuring water trucking in locations and times when there's absolutely no water available. I believe those were the key points from our group. If I've missed anything or anyone from the group wants to jump in, please do. Otherwise, I'll hand over to the next group. Thank you. Amal, go ahead.
Yeah, just one other point to take into account is thinking about nutrition and how cases of malnutrition usually lags behind other illnesses. So if it's a mobile health and nutrition team that focuses too much on the health part, that the nutrition part needs to also be, particularly, for example, in floods where you can have acute episodes, then after the malnutrition then is a couple of weeks behind or a few more weeks behind the actual peak in illness or displacement. That's just the other point needs to be put.
Thanks, Reka. Thanks, Amal, for those additions. I am going to hand over to my colleague, Sajia Mejabin, who's in my team. I think, Sajia, you are feeding back from the integration group. And can you just let me know in the end how you decided to feed back? Will it be verbal, or do you want me to share anything?
I just shared the slides with you and Gillian. So otherwise, I can also go.
Nope, just give me 1 sec and I will get them up. Stop share 1 sec. You share. You want to start in? I will be 2 seconds behind you,
Okay.
Sajia.
Well, I mean, there was a really, really interesting discussion in our group because we tried to answer one of the most difficult questions, how to kind of ensure health and nutrition integration in the health facilities. And there were a lot of interesting points that came out. So the first thing that we discussed was the first recommendation from our case study. It was for the donors and the policymakers that promote an integrated funding streams and coordination for health and nutrition services. So on this recommendation, we have noticed that we didn't specify the type of integrated services we are talking about because it can come it can be primary, secondary, or tertiary level. So in the recommendation, we have to be very clear of what type of services we are talking about. It can be like basic package of health services, or it can only focus on the vulnerable groups, but we need to specify it. We also need to kind of consider the GBV package as a part of the health package, especially in a fragile context like South Sudan. One of the interesting discussion that we also had is that we always have a different protocols for nutrition and health services. So even if we want to kind of integrate surge approach, it is integrated into the CMM protocol, but not in our overall health strategy. So to bring all that just together and kind of coming up with a holistic approach is really needed, and we need to advocate for that so that it is not seen as a nutrition protocol or a health protocol, but as a joint protocol which talks about both health and nutrition service delivery. So something like IMCI, like the trade that you presented from Ethiopian case study, something like IMCI, we need to kind of focus on. Another thing that was highlighted was that we need a comprehensive need assessment and not a siloed one. We need to quantify the need for not only nutrition. So for example, it's a mindset. I think for us, the technical expert, like a nutrition or health, is to only focus on the areas that we are addressing. So only focusing on nutrition or health and trying to say that the gaps are in nutrition services or health services. So we need to break that approach and kind of, even for the nutritionists, when we talk about gaps, it's not only about gaps in nutrition services that we should talk about, or only the prevalence of malnutrition. We also need to talk about the gaps in health services. So only nutrition treatment is not going to help if there is a gap in health services. It's a no-brainer. And the opposite is also true. So we need to come together to kind of push for it. So that was some of the key consideration for the first recommendation, which talks about how can we promote the integrated services and how the policy and decision makers can take it forward. So now going into the next one, which is mainly for the implementers. So we talked about like there are different approaches that all of us have already like taken in previously to ensure health and nutrition at the head district and health facility, but like it shouldn't be that complex. It can be very simple as coming up with a very simple integration matrix with some practical action plans, identifying who will do what, having a timeline, having an M&E matrix, and focusing only on the health facility level, and it can work. This recommendation, I think no one objected. So this recommendation is like some of the key consideration that we discussed is that integration is a continuum. So even when we talk about integration at the health facility level, we need to identify, understand some ultimate goal that we want to achieve. It can be medium term, short term, or even longer term, but the goal have to be there. Like what is next? Okay, we have achieved the integration at the health facility level. Maybe we brought in the county health department, but what is next? So we need to come like when we kind of start the process, we need to identify a clear goal for that. Another interesting thing that came out is like revisiting the way the implementing partner sees its role in the health and nutrition services. So most of the cases we've seen that like our role is mainly technical, but when we go into dig deeper into the health and nutrition integration, looking at the building blocks, there are big bottlenecks, which is not like, of course, they really require technical, but that necessarily doesn't mean a very nutrition technical perspective or health technical perspective, and identify what we have the biggest impact. So most of the time we see that us as an implementing partner are not looking into the biggest constraint, which could be the outreach. So we need to change the way we are doing things. We need to change our mindset and kind of come up again with a holistic approach, not only focusing on the technical aspects of nutrition, but looking at the overall system and how it is operating. That would help. We also talked about supplies and how it's one of the major challenge that we have separate modalities for nutrition and medical supply. But we also say that maybe this is the bulkiness of the RUSS supplies, and the capacity of the ministry to manage maybe is a major challenge. And maybe that's why it's managed separately. But we couldn't come to a solution as to how to ensure that the health and nutrition supplies are managed as not a separate way, but as a whole. One of the questions that, again, we didn't have any answer to, that if we really want to advocate about the supply issues, not only RUTF, RUSF, but the fragmented supply of amoxicillin and all the stabilization center supply, what should be some of the key points that we need to consider if we want to advocate to the donor? And we couldn't come up to an answer. Sorry about that, but that was all we discussed. Unless I missed anything, please feel free to add.
Thanks, Sajia. In the interest of time, I might say, unless there's anything burning, but I think you covered it with some key points. And now I am going to hand over to Gashane, our ERNE program manager in Ethiopia, who is in the nutrition supplies group. And Reka is going to share her screen with some key points from that group. Gashane, over to you.
Yeah, thanks, Kate. So in our group, from the case studies from Ethiopia and Sudan, we pick up two of the most important factors for supply breakage, that's transportation and monitoring. So we have been discussing how we can strengthen the transport and how we can strengthen the monitoring of the supply system. So on the first point, we agree that we need to choose a suitable transportation mode that are suitable for the continent. So there was an argument that should we stick with the traditional means of transportation like donkey, horse, and or the current transportation means, and or should we have to find an innovative way of transportation? So finally, what we have agreed is we need to see the condition of the continent. So in areas where we cannot use motorbikes or the other innovation means of transportation, we may still stick on donkey and horse transportation. And we have to also consider the seasonality in the area. And the other thing is, it's important also to reflect how they will be financed. How to we account for inflation. So this should also be considered whenever we plan to strengthen the transportation. And the other point is we need to engage also the community component as one part of the important and one important aspect. There is an experience from Niger. Community actors need to be engaged. For example, each commune in Niger has communal annual plan with the budget for the transportation of supplies. And we need to also, there is an experience to engage diasporas to support the transportation system. And we need to also advocate on to the government to allocate sufficient budget. This will also help to ensure the sustainability. So rather than, most of the time NGOs are mainly focusing to support the transportation system in an ad hoc basis. So rather than sticking on this approach, we need to pull out all the means of budgeting into a single pipeline. It can be from diaspora, it can be from donors. So we need to bring into a government pipeline, and so that it can help to strengthen the sustainability. And the other thing is we need to advocate also to UN agencies to have better coordination. Lack of coordination is one of the significant challenge, which is coming again and again. And so UN agencies in collaboration with Ministry of Health have to work on to strengthen the collaboration, in integration. So the role of responsibility of NGOs will be to focus mainly on the emergency periods. The government system will be overwhelmed in this case. So NGOs might be jumping in to directly support the transportation system. And they need to also work, consider how the search approach could be, can support the system. And they need to also see the capacity of the government before just planning their intervention. And on the monitoring, so monitoring of the case load, forecasting, considering seasonality at local level and being communicated up, but is one of the important things that we have to focus on. But still there is a problem on the coordination, as I've mentioned earlier. And joint monitoring and evaluation system should be strengthened. There is a good experience shared from Kenya by WFP. There is a system that the government, as the facility level staff, will SMS any stock out. And this is a joint initiative between WFP, UNICEF, and the Ministry of Health. Even if it is a simple tool, it have brought a significant impact, and we need to adopt this also to other countries. And finally, NGOs have to also work on to have contingency supplies. They need to convince donors to have a contingency stock to ensure sustainability of nutrition products whenever needed. This was the whole discussion, but if I miss any important point, maybe the team member might jump in. Thanks. Over.
Thank you, Gaishane. And so I have 1 minute before it's time for lunch. I don't think I need to summarize what came out of those working groups. They were very, very clear, and we are going to take them away and all the documentation and be sharing a summary of the whole workshop, which includes some of our thoughts and your thoughts. But I have to say, I'm really encouraged that I think some of our initial learning that we shared was reaffirmed by the groups, and that we have, I'll come to you in a sec, Mariama, that we have, that we're on the right track. And I think the other thing that really strikes me is that these aren't necessarily technical issues. They fall somewhere between very serious operational issues. There may be some technical improvements to streamline these things, but we need to find a forum where the logs people and the technical people and the program managers can discuss these very practical challenges and ensure that we have the resources lined up and efficiently channeling into these fragile contexts so they can deal with them.